Hi, everyone, and welcome to our program today, Follicular Lymphoma, the latest treatment options for me. My name is Stephanie Trong. I'm the founder of The Patient Story, and more importantly, a blood cancer survivor myself. I went through treatment, hundreds of hours of chemo for my diffuse large B-cell lymphoma diagnosis. That was a few years ago. And it was during that time I realized how lonely it was and how hard it could be to get really good information. And so that was the genesis of The Patient Story, with the goal of helping patients, care partners navigate life after a diagnosis, answering what does this mean in human terms. We do this primarily through in-depth patient stories and educational programs like this one. This is especially important, we feel, in spaces like follicular lymphoma, where, as you know, patients and their families and loved ones are being told by doctors many times, look, this is highly treatable, but it's not curable. So it's really great to be in the know about the latest therapy options and clinical research. We really stand behind this message of self-advocacy, especially after diagnosis. So before we get to our incredible panelists, we do want to say thank you to GenMab for its support of our independent educational program. That support helps us host more of these and for free for our audience. The Patient Story does retain full editorial control of all of the content. We're bringing this to you in collaboration with the Leukemia and Lymphoma Society. For those unfamiliar with the LLS's work, it has raised and invested over $1.5 billion in blood cancer research and provides free educational resources and support, like their information specialists, who will provide one-on-one support on questions from treatment to social and financial challenges. While it is really great, we hope that you would walk away after today's program with more knowledge. We want to stress that this is not a substitute for your medical advice. And lastly, it's really important that we hear from you. We want to know from today's program, as well as the other things that we do, what did we do well? And more importantly, what could we do better? Your perspective really helps us to make sure that we do better and more for you. And we also want to understand what else you want us to cover in the future. So please fill out that survey. It'll just take a few minutes and it'll come up after this program is done. Okay, now the housekeeping is all done, and now we get to the good stuff. Our discussion today focused on the latest treatment options for relapsed refractory follicular lymphoma. First, I'd love to introduce someone who's going to help us lead the discussion today, my co-moderator, Dylan Lepak, who is another non-Hodgkin lymphoma survivor who also became a patient advocate. So Dylan, I'll toss it to you to introduce yourself.
Hey, my name is Dylan Lepak. I am a diffuse large B-cell lymphoma survivor, just like Stephanie. I was diagnosed in 2021, went into the hospital with some stomach pain, came out with a horrible diagnosis. But luckily, I had a very, very standard kind of treatment approach. I went through 6 cycles of RCHOP, and since then, I've been good. And since that period of time, which was in 2021, I've done a ton of different charity work, both locally. I live in Oklahoma. I moderate some discussion boards and various different things, kind of peppered everywhere all over the internet. And I'm here with 2 amazing doctors, one of which is Dr. Celeste Bello, who is a hematologist oncologist, and hopefully this is correct, senior member in the malignant hematology program. Is that what you guys call it? Yeah, at Moffitt. And you have a special expertise, definitely in Hodgkin's lymphoma, because you sit on the board, the NCCN guidelines for Hodgkin's lymphoma. You also do a bunch with follicular lymphoma, and from what I saw from your research, you seem to have a kind of a little bit of a special interest in CNS lymphoma as well. And so the first question we always ask everybody is, when you first see a patient with lymphoma and they walk out of your office, kind of what is the biggest message that you want them to take away after that first meeting?
During my first meeting with most of my follicular lymphoma patients, I'm really trying to convey that they can just relax, take a deep breath. We got this. In most cases, we can manage this quite well, and that's really a lot of the part of the meeting is trying to get everybody anxiety down a bit and say, hey, we got this.
Yeah, awesome. Thank you, Dylan. Thank you, Dr. Bello. And now I get the pleasure of introducing another amazing doctor and leader in the space, Dr. Josh Brody, a hematologist oncologist Director of the Lymphoma Immunotherapy Program at Tisch Cancer Institute at Mount Sinai, New York, faculty member of Icon Genomics Institute. Since 2011, developed the Brody Lab, a translational cancer immunotherapy lab, which investigates development of novel therapies, especially for spaces that include lymphomas. Also specializing in how to use immunotherapy against treatment-resistant lymphoma. So, Dr. Brody, that was a mouthful. And I know that you're very invested in patients beyond the clinic. What is your message in the follicular lymphoma space when you see patients, their family members in that office? What are you hoping they walk away from that first meeting with?
It's very much like Dr. Bello said. I'll sort of even paraphrase another version of it, which is that some lymphomas, aggressive lymphomas are a sprint, and we need to get things going right away. But big picture, follicular lymphoma is a marathon, not a sprint. If you see someone starting a marathon by sprinting, they're not doing it correctly. So it is just like Celeste said about pacing oneself, taking a deep breath. And then we don't want to overwhelm people with information the first time we meet them. Like as Celeste said, give them the big picture that hopefully this is going to go very well. But it does involve planning ahead. And when I say that, it means that there's a lot of great medicines for frontline therapy and a lot of great medicines for second line therapy. Some patients might need things for plan C, plan D, plan E, and how you develop plan A and plan B might impact those. So even though there's no emergency for the vast majority of these follicular lymphoma patients, plan A and plan B might affect plan C. So if people want to really, plan out their marathon thoughtfully, you're going to have a drink at mile 7 and a granola bar at mile 10. You can say I'm not a real marathoner. But planning the whole thing out as best we can, right? We have to be flexible because we're going to have to change the plan depending on how things go. But yeah, take a deep breath. There's no emergency here, no sprint. But I mention all that plan C, D, E stuff because sometimes plan A and B, there are unique options which are available at some places that may not be available at others. So we shouldn't just say, we've got a lot of easy stuff here for plan A. We might want to do the smartest plan A so that we don't burn bridges for down the road maybe, yeah.
Yeah, absolutely. I appreciate both of your responses on that. It's clear you're very thoughtful about the approach with patients and the care partners who are in that room. And we will be addressing the fact that, of course, with follicular, it's so different than what people are seeing in the movies. It's like you are describing, it's, a marathon, and that there's going to be different long-term sort of planning that's going to be involved. And I think in this space, it's great to see the two of you because these are long-term relationships, right? It's not like an in and an out. So thank you for that. Would like to kick off the discussion by going over, because we know there are, dozens of kinds of non-Hodgkin lymphoma, and people who are tuning in today are, of course, very aware of the nature of follicular. But if you could, Dr. Bello, summarize some of the nature of follicular lymphoma, that would be amazing.
Well, I think follicular lymphoma is kind of interesting disease in that it is kind of broken down into different subtypes within this subtype. We have our low grade indolent ones, which are the slow growing ones, and this is a pathological or histological grade. The pathologist will tell you which category this falls into, and then there is a one subtype that is a little more aggressive than the others. So we usually will address it as low grade, which is usually if anybody's had follicular lymphoma, they'll see there's a little grade next to it, grade 1, grade 2, or grade 3A. And then there's the high grade kind of rapidly progressing one, grade 3B, which we refer to as more of a high grade. So most of the times we're talking about this low grade, slow growing one when we're talking about follicular lymphoma. And basically, I mean, the characteristic is that a lot of these are very slow growing. They're indolent, a lot of times picked up by accident, picked up on another diagnostic test like a mammogram. That's a common one I see, and somebody had a screening mammogram and no problems with any evidence of breast cancer, but oh, by the way, there's an enlarged lymph node in the underarm area and the axillary area. So I think what I usually think of with lymphomas or follicular lymphomas is that you have your low grade category, and that's what this falls into in the majority of cases. There are some that can behave kind of aggressive, so we have to keep an eye on these people. And then there's some that we know will behave aggressively, and we treat them differently. But as a whole, like Dr. Brody mentioned, it is a long-term disease. I usually tell people it's kind of managed like a chronic illness, like your diabetes. We try to keep it under control, and if there's a flare of it, we can get it. We can manage that in most cases. It is a cancer. It's a cancer of lymphocytes, but one that sometimes doesn't even need treatment, and we can just observe.
Yeah, yeah. I mean, I think you hit the nail on the head. Usually, when I'm talking to a bunch of patients or on discussion boards, like a lot of them, it's incidental, right? It's like a CT scan or a scope. But if they do have symptoms, like what are kind of the symptoms you usually see in a patient with follicular lymphoma, Dr. Brody?
Yeah, as Dr. Bello said, it is like, and as you're noting, Dylan, the majority of patients are asymptomatic when they get diagnosed, and the amount of that depends on where you're living. If you're in a country where they get CAT scans for every time that someone sneezes, then yeah, they get diagnosed and probably never should have get diagnosed. Actually, since I think Steph was asking me, amongst the first things we have in the first conversation, I probably should have thrown in that I got specific permission from my grandma. My grandma died at the age of 101 a couple of years ago. She was a very nice grandma, and she didn't have follicular lymphoma. She had the next cousin over, the next indolent lymphoma over, but treated in a very similar way as all these low-grade B-cell non-Hodgkin's lymphomas. And we gave her this therapy. We're going to talk about those in a second. I'll get back to symptoms. We gave her active surveillance, watchful waiting for 37 years, never needed any therapy. So she was asymptomatic. Most people are asymptomatic. But yeah, some people can have symptoms. They mostly don't have the Google symptoms, the symptoms that Google told them about, which are the B symptoms: fevers, night sweats, and weight loss more than 10% of your body weight. Those are pretty rare, actually, for follicular lymphoma. Less than 10% of patients for sure. 90% of patients don't have those. Most common symptom is a painless lymph node. And the phrase painless is probably real important, because if you got a sore throat, you got strep throat or whatever, you're going to get painful lymph nodes there. But painless, totally non-tender. When I was shaving, I noticed it. But painless adenopathy is the most common symptom for sure. And those B symptoms, weight loss, fevers, night sweats, pretty uncommon.
Great, great. Thank you. Thank you so much. Before we dive into talking about treatment and the landscape, want to kick off also by talking about, you just said watchful waiting or active surveillance. I know some people really don't like that watch and wait as a term, but that can be really tough, of course, for so many people, that mismatch and being told you've got cancer, may not be treated right away, or you may be waiting. So, would love to hear from you both on this, but how do you describe that period to your patients? What term do you like to use? How often are people told they're on that, watchful waiting or active surveillance? What is the plan that accompanies that? And we can start with Dr. Brody, and then Dr. Bello would love to hear from you as well.
Yeah, I grew up saying watchful waiting. And then a couple of years ago, I have to probably credit Mike Schuster's lymphoma doc out at Stony Brook, not to be confused with Steve Schuster, another lymphoma doc at UPenn. And I think Mike told me he patented the phrase active surveillance. I'm not sure if he patented the phrase, but it sounds a lot better. Active surveillance. We're going to actively surveil you as opposed to watchful waiting. We're just going to sit around and do nothing. It's all about branding. The reality is we're going to keep a close eye on you. I just use the phrase, we're going to keep a close eye on you. And how close depends on what's been going on with them and how well you've known the patient and for how long. And let's just say this very simply. This concept is super freaky to patients and their families when they first hear it, but is 100% of the time, a year later, their favorite concept. Sorry, I shouldn't say 100, because some patients don't get surveilled for that long. But for every patient that is still on active surveillance a year later, they love the concept. But on day zero, wait, what? What am I going to tell my friends when they ask me what happened to the doctor? Why didn't he treat me? Because bad insurance. Why aren't you treating me? Because cancer, no treatment. It sounds super freaky. But mostly I just come in with my grandma's story. And then when they hear that sometimes this can go for decades without needing therapy, the only test, all of our fancy tests, biological tests, radiological tests, the only test that tells you if you're going to go down my grandma course is the test of time. So we're going to give you that test of time. There is no test as good as that, but we're going to watch you closely as we start to give you that test. I forgot if I answered the question now. It was just how we make that work. Yeah, it's super freaky on day one and usually super chill by a year later.
Yeah, I feel the same way. it's always so funny. You have these people that it was picked up incidentally, and you tell them, we're just gonna watch you. I usually use observation as the term, or but just keep an eye on you is a good phrase for that. And some people are like, oh, thank God, that's what I wanted to hear. Other people are like, oh my God, I'm getting a second and third opinion. And they just can't take it because they're like, I can't. And I feel for them, honestly, because I think, since some of them are picked up by accident, I always wonder, man, would it have been better if we picked this up 20 years later? Are we doing a disservice that we diagnosed this little lymph node under their arm? We have left it alone to begin with, because now they're going to have, 20 years of anxiety. Instead, they were living, life peacefully and bliss. And I get the anxiety can sometimes be actually the hardest part of the diagnosis.
Thank you for that. We wanted to make sure to address that as well as one other thing before we again kick off with Dylan asking about the current treatment landscape. But something that we've seen a lot on the patient forums or hear from people in our community is it's this mismatch again of, this diagnosis of cancer and kind of coming into it the mindset of we need to get it treated, and then hearing you're not going to get treated, much of the time. So one comment was from a follicular lymphoma patient, Donna P, that said it was more of a comment than a question. She said, one of my first questions was, how long will I live? Until I found a support group, I was so depressed and fanatical about my disease. Then I started seeing all the comments and how longevity was in my diagnosis. And so many others then gave me hope. Do you at all in the initial conversations with the patients, when they're dealing with so much, do you have any guidance for them, whether it's there are support groups or resources on hand here, especially because they're being told you'll be living with this. It's going to be treated more chronically. Dr. Bello?
Yeah, we usually give them a booklet from the American Cancer Society that has kind of a summary of the different types of non-Hodgkin's lymphomas. But I always like to tell them, because everybody nowadays runs to the computer and they do Google everything. I tell them, don't do Google. If you want to go to some websites, I usually recommend LLS, and then the Lymphoma Research Foundation. Both of them have very good websites with patient information. But those are the two go-to that I usually use.
My first recommendation always is they should go to the patient story, which is available online. And then if somehow if the website were down, which would never happen, then yes, absolutely. Just as Celeste said, Leukemia Lymphoma Society, LLS, or Lymphoma Research Foundation, LRF. There's a few others as well, but those are the best for lymphoma patients. And then we also sometimes have in-person groups. And also, if someone, as Celeste said, the stress of this can be a significant thing, especially for someone already had stress as a problem before, or anxiety as a diagnosis before. So we actually, can try to get them personalized counseling. And hopefully, at cancer centers, we're very lucky to have counselors that have nothing but experience with cancer patients specifically, or in our case, our therapists with lymphoma specifically. So I think that can be very helpful as well. Yeah.
Okay, so we're going to dive into the treatment options, which there are a million, and we're doing novel. But before we kind of go into novel, you talked a little bit about this, but can you give us a breakdown of what the standard in the first two lines? If you're follicular lymphoma, you wait forever, you finally need treatment. Hopefully you have another very long period, and then you need treatment again. Kind of what does that look like?
I think the standard is there's no standard. So so that's always the first problem. I should say problem, but it's a good problem because we do have a lot of different options, and you like to kind of base it on the patient that you're treating and kind of what your goal is with the treatment. Some people, it may be that they have one large lymph node that's causing them discomfort, and you may say, hey, radiation to that spot may be the best option for you. You may have some people that have just a kind of a generalized symptoms like fatigue that's really severe. It's interfering with some of their daily activities, but they don't really have a lot of disease. And in that case, you may just want to give them a lighter, less intensive treatment like a monoclonal antibody like rituximab, and put it into remission and see if it corrects their symptoms. But then you'll have other people that are very symptomatic. They come to you with rapidly growing lymph nodes, can have fluid buildup in certain body cavities, like in the abdomen, and you want to treat them with something that's going to work quite quickly because they're clearly hurting, and that's usually a chemotherapy plus immunotherapy regimen. There are a few available. One of the more popular ones is bendamustine plus rituximab or plus obinutuzumab, which is also another monoclonal antibody. But there's also milder or less or non-chemo approaches, oral therapy with lenalidomide and rituximab. But there's a few options, and it has to be geared kind of towards the patient, which patient you're treating, the fitness of the patient, and what your goal is with the treatment.
Fantastic answer. So now we'll get into the novel ones, and kind of the cool kid on the block right now is bispecific antibody. Before this, it was CAR T, but that's old news now. We don't even think about that anymore because bispecifics are, I think I like ASH, which is like the biggest hematological conference. There were like 19 readouts in follicular lymphoma alone for bispecifics. They're massive right now. They're all over the place. And so, Dr. Brody, can you kind of give us an idea of, in, I guess, human terms, what are bispecific antibodies? How are they different than CAR T? Kind of what's their mechanism of action?
Yeah, great question. Between graphical help here and using my hands, I'm going to answer the question pretty simply. Dr. Bello mentioned that one of our go-to therapies over the last 24 years is these things called monoclonal antibodies, anti-CD20 antibodies, especially rituximab, obinutuzumab. Rituximab is certainly the most famous, and it is an antibody, just like we make anti-COVID antibodies, anti-flu antibodies. This is an anti-lymphoma antibody. Anti-CD20 is one little protein marker on the surface of lymphoma cells. So bispecific antibodies are just kind of two of those, an anti-CD20 antibody usually. We have other versions as well, and another antibody which binds your immune cells. And CD3 is a marker on these immune cells called T cells. And I think this was my buddy in Nebraska who made up this phrase. This is just like the noodle in Lady and the Tramp, when the Lady and the Tramp puppies were both sucking from the spaghetti dish at the same time, and they ended up accidentally sucking on the same noodle, and it brought the two of them together. That's a very romantic movie between two puppies. This is, instead of that, called now the kiss of death, instead of the kiss of puppies, where the lymphoma cell and the immune cell are brought together, and it activates the immune cell at the same moment, so that immune cell, that T cell, kills the lymphoma cell. And T cells are incredibly good at killing lymphoma cells, better than probably just about any other cancer. And as you hinted, it's kind of the same idea as the CAR T cell. The main easiest difference there is that for CAR T cells, to teach that T cell to do the job, we have to take the T cells out of the person, ship them to Santa Monica or somewhere, and then get the CAR T cell made there and then ship it back. And there's a bit more, a couple other complicated steps as well. This is just sort of, in some ways, an off-the-shelf version of that. So you can use it today. You don't have to take cells out of a person, mail them somewhere, and then have them mailed back. So in that way, it's similar to an off-the-shelf CAR T cell. Not exactly, but pretty close. And they've been incredibly effective at melting away lymphoma cells, even when other therapies like chemotherapy and lenalidomide and a few others have not been working. And especially when rituximab, that single antibody, has not been working. Still, these bispecific antibodies have been awesomely effective in inducing, in follicular lymphoma, remissions in the great majority of patients. It's been an absolute revolution. That is not an overstatement, because we didn't have anything nearly as effective and safe as this until bispecifics came along, I would say.
Yeah, thank you, Dr. Brody. I love the imagery that you bring to the discussion.
It was Matthew Lunning at Nebraska, who I think made up the Lady and the Tramp one. I want to make sure I get that
right. The kiss of death. Yes. Okay, we will rightly attribute that to him. But thank you for the gesticulating and all that. That was really, it is helpful, because I think sometimes we hear in the doctor's office like these things, we have no idea what's actually happening. This can be very helpful. So thank you. And so on bispecifics, we have 2 FDA-approved options in follicular lymphoma, so far. Lots of different names also floating out there in research. So Dr. Bello, for what kinds of patients would you be recommending bispecifics? is there anything practice shifting for you? I know that there's conversations. I know you're both at major institutions. I know that bispecifics has become a lot of conversation for people who might be getting treated elsewhere, like in the community. So, and as we know, the two approved, if we could start with those two, that would be great.
Well, the first one for follicular lymphoma was mosunetuzumab. And now recently, in the past, I guess, month or two, maybe it's been 3 months. I always lose track of time. The second one, epcoritamab, was approved for follicular lymphoma. So we have those two options. I think with follicular lymphoma, thankfully, the majority of these these lymphomas are pretty indolent and respond very well to the frontline treatment, whatever you use. If you use a chemoimmunotherapy like bendamustine and Rituxan or obinutuzumab, both of those, the monoclonal antibodies. Whereas where we kind of have the luxury where a lot of our patients don't end up needing to get a bispecific antibody. But for the people who progress despite the bendamustines, the Rituxans, the Revlimids, now we have these immunotherapies, the bispecifics and the CAR T, which I know we'll talk about later. But so I kind of use the bispecifics more in people who have progressed on these other lines. I always try the other lines first, unless we have a clinical trial. They're proven, bendamustine and cyclophosphamide and Rituxan, and they have a great track record. And so I use those first. I don't skip right to a bispecific. Bispecifics do have some side effects that are very unique to them and may not be the best for everybody. They do also require a little bit more skill in monitoring them. They're administered sometimes in the hospital at the beginning, something in the office for the subsequent doses. But I really use it for people that are resistant or relapsed after two lines or more of treatment, and who also are not.
Thank you for that. Yeah, thank you for that color. Dr. Brody, what about you? Do you have any additional notes on how you approach bispecifics? And then also with a couple of options, how you might decide one over the other for somebody?
Yeah, it's just as Dr. Bello said, we were very lucky to have these two now FDA approved just for the last little while, months and a little more than a year for the other. And so their kind of role is evolving very rapidly, and it will be evolving very rapidly over the next few years, because I would absolutely not be surprised, or let me say, I would expect that in 5 years from now, bispecifics will be an option for frontline therapy, maybe given by themselves. But honestly, I really don't think that is the future of them. I think the future is just like rituximab, to become part of combinations therapy. And yeah, I'll give you a straightforward answer in a second. But Dr. Bello was doing some comparison between CAR T and bispecifics, and I agree very much with what she was saying. But in the future, it will be maybe an irrelevant comparison, because it won't be what's better, CAR T or bispecifics, because bispecifics will usually be given in combination, maybe together with lenalidomide, as Celeste was mentioning, as a common standard therapy, or in other combinations. So it'll be a little apple and orange comparison. Who cares what's better, because we don't give them, probably in the future, we won't be giving bispecifics by themselves. Today, they are only FDA approved to be given by themselves today. So the only way to get them as part of combinations is as part of clinical trials. And some of those preliminary data from those trials of combinations of bispecific plus standard therapies like lenalidomide, the results have been awesome, with like the huge majority of people getting complete remissions, and in some cases even when prior chemotherapy and such weren't working. So yeah, I think I feel similarly to Celeste today. They're only approved as a third line therapy, Plan C, when Plan A and Plan B haven't worked. So that is for my patients that are not on trials. That's how I give them. You asked me to compare the two. Celeste made some of the most salient points. Medically, those two approved, the epcoritamab and mosunetuzumab, pretty similar efficacy. I think pretty similar safety. So most of the differences are just sort of logistical differences. So I'll give the two main logistical differences. The one epcoritamab that was mentioned is given sub-Q under the skin, just like a shot, and the other mosunetuzumab is given IV. For many patients, it doesn't make a difference. They don't care. For some patients, especially the patients that have had 12 prior lines of therapy and their veins have gotten all beat up, it does make a difference to them. Or some patients have a port and they don't want to have the port still in, or they don't want to get a port. So for them, sometimes sub-Q therapy can be a big deal. So maybe that's a point in favor of epcoritamab. And then Celeste said this very well and eloquently, that the mosunetuzumab is sort of a finite course of therapy, about 9 months. And that is nice to get it done. The epcoritamab is written that it can be given until it stops working or until you have a bad side effect. I'll just tell you a secret. Now, please never, publicize this video. Of course, we have a lot of patients who have been on it for a year or two, and the patients just say, "Okay, I'm done. Let's just pause it for now," and we're okay with that because it's not exactly the recipe as written, but we don't feel like we're burning any bridges, because if their lymphoma were to grow back, we might be able to treat them again. So even though it says give forever, not all patients have to get forever. Some patients, strangely, prefer to keep going because they don't like the notion of doing nothing. And because it is more total dose of the epcoritamab, for me, it's kind of simple. If I have a patient who lives across the street and they don't want any IV therapy, that patient gets epcoritamab. The patient lives 4 hours away and they feel strongly about not too many trips, and they don't mind getting IV therapy, that patient gets mosunetuzumab. So, this is something where actually patients are involved in the decision. Not everywhere is the patient, the big decision maker, but in this space, I think patients have a big role in that decision.
And I know we can get into this later, but I still kind of prefer CAR T therapy over the bispecifics because I just see more durable responses. But not everybody can wait to do the whole manufacturing process. Like Dr. Brody mentioned, you have to collect the T cells, send them to be manufactured, then send them back. Well, by now it's 6 weeks have gone, 4 to 6 weeks have gone by. And sometimes if people are having rapid progression, they can't wait and you need the off the shelf. And then the CAR T can have a little more, I would say, toxicities with them. The patients are hospitalized a bit longer during that. So not everybody has a performance status that's, I guess, robust enough for the CAR T. So that's when I would use the bispecifics.
Dr. Bello, you touched on some of the side effect profiles of bispecifics that are a little bit different. I actually looked at the original Rituxan study before I came on here. It actually had a pretty decent side effect profile. There was like fever in 64%. So these have these cytokine release syndrome, which luckily we don't have to explain that much because COVID kind of made that part of everybody's vernacular. And also a small number of I think you said much less than CAR T, but there are still a small number of neurological events. Can you explain kind of what those are? And if I was like a caregiver or a patient, like what should I be on the lookout for? And maybe what would my experience be like? I'd like to pose the question to both of you, but Dr. Bello first.
Well, like you mentioned, a lot of people are now familiar with cytokines and cytokine release syndrome, which is basically, I usually tell people, my patients, it just mimics the most severe infection you've ever had when it's bad. It can be mild. So basically, the symptoms are fevers, chills. Sometimes, though, it can be more severe than that. Sometimes it can be a drop in blood pressure. Sometimes it can be leaking of fluids into your tissue and into the lungs. So it can be more severe in some cases. The bispecifics really they don't really cause much of that in most people. So it's been kind of nice that we err on the side of caution, and with a lot of them, when we first give them their we kind of do it in a step up dosing where you start with a small dose, have them come back a week later and give them an increase, and then a week later an increase. We sometimes hospitalize them to monitor them for like 24 hours, but majority of the times they do very well. But that's the symptoms you're really looking for with the cytokine release. It's the fevers, chills, and sweats. You can definitely get the sweats. The neurologic toxicity, which a lot of times is abbreviated ICANS or ICANS. That's more serious. That can be confusion, just word finding difficulties, or it can be as severe as being obtunded or in a coma. So that's a more severe thing. But again, we don't really see that much of it with the bispecifics. So fortunately, it's not something we really need to look for. I mean, we let patients know about the possibility, but we don't usually see that.
Perfect. Dr. Brody?
Yeah, Dylan, when you mentioned the COVID and cytokine release syndrome, I wasn't sure if you mentioned COVID meant like COVID the infection or COVID the vaccine, because even vaccines, you get a shot in your arm and you get a fever. I mean, half the people with COVID vaccines get a fever. And again, another deep, dark secret, that is also cytokine release syndrome. It's just a little achy shoulder for about a day and a fever of 101. So, Dr. Bello was very thoughtful in reminding people this can be a severe thing. At the same time, I don't, and it can be. So the patient, and even more importantly, as you said, Dylan, the caregiver, the spouse or the friend or whoever's hanging out with the patient after their first couple of doses, that person really needs to know about, just as Dr. Bello said, it can be a severe thing. But then we'll also like to tell people about the reality and the statistics, and almost all of the patients actually with the follicular lymphoma bispecifics. And if they read too much on Google, they'll actually, unfortunately, also read about aggressive lymphoma bispecifics and mantle cell lymphoma bispecifics, where the numbers are actually a little bit worse. But in the follicular lymphoma bispecifics, the most done in the EPCOR, almost all of these are low grade, meaning that all it is just a fever, or fever and a little bit of low blood pressure, but enough that you could just drink fluids and solve it in a few hours or a day. And similarly, that those neurological syndromes, icons, as was mentioned, in the biggest studies for the follicular lymphoma patients, it was the high grade version of that, where people are really confused. It was 0% in all of the recent studies. So we do have to tell people about that. But at the same time, we want to tell them the likely thing, not just what might happen, but what likely will happen. And what likely will happen is about half of patients get a fever, and they get it either on the first dose or the first few doses. It depends which of the bispecifics we're talking about, but certainly within the first 3 or 4 doses. And then if a person's getting many more doses in the future, they almost never happen. So that is a nice thing about this side effect. Most side effects in cancer therapies kind of get worse as you go. Low blood counts, infections, all of those things. They usually get worse as you go. The first cycle is not bad, but by the third or fourth cycle, you guys here both had chemotherapy. And I guarantee cycle 5 was worse than cycle 1, even though I didn't know either of you at the time. And bispecifics are the opposite, really. It's just that first couple of weeks has this risk of the fevers, and then that risk goes to about 0. I don't want to say there's no risks, because there still are some risks. The risk of infections of these common flu, RSV, COVID, these common viruses that are around, those risks are real. But they're true for almost every therapy we give. And they're even true for some lymphoma patients who are not even on therapy. So I don't want to say that there's no risks, but those are kind of the common risks that most of us are facing. But the main thing, the cytokine release syndrome and those neurological side effects, they mostly either happen in the first few weeks or they never happen at all. So in that way, it's a bit of a comfort to a patient, because once they get through the first few weeks, they're kind of, I don't want to say in the clear, but they're definitely in the easy running part.
Thank you. Thank you both. Before we move from bispecifics, we're going to talk about CAR T. Just a question about access, because we get a lot of those kinds of questions. Okay, we hear it's all great, but when CAR T first came out, some people were, there were some issues with the access there. Not to mention that, it has to be done at very specific places like your institutions. What are your thoughts about bispecifics and the access that people may have? Because I think the hope is that there will be more of it, but just in terms of what you're saying, Dr. Brody, would love to start with you, and then Dr. Bello.
Yeah, that's supposed to be the main, transformation and revolution about bispecifics. So they're supposed to be accessible, and I really think that they are, or definitely that they will be. So again, let me make a little distinction. For the aggressive lymphoma bispecifics, there is this speed bump that Dr. Bello mentioned, which is for both of the ones that are approved now, there is a mandatory 1-day hospitalization. It's not that bad, 1 day in the hospital, but that becomes a real pain in the butt for docs who have to kind of coordinate that. Even though it's not medically such a big deal, it's logistically a pain in the butt. Still a lot easier than CAR T, which can be weeks in the hospital sometimes, but it's still not nothing. By contrast, the follicular lymphoma bispecifics that we mentioned, epcoritamab, mosunetuzumab, the FDA label and the way that we do it is no hospitalization is required. And we occasionally will have a 90-year-old patient and we're just worried about, and we will admit them just to be safe. But for most patients, there's no hospitalization required. So that makes the accessibility hugely more doable than CAR T cells, or even easier than the bispecifics for aggressive lymphoma. So, I think the main obstacle to accessibility now is just that community oncologists are just kind of getting comfortable with these. because they're just recently FDA approved and they haven't used them a lot before. But, doctors like Dr. Bello and I, who've been using these for years as parts of trials, we're pretty comfortable with these. Just like Dylan said, rituximab sounded scary when it was, first released 24 years ago, and it was a big deal. People had infusion reactions, and now we just say, oh, by the way, infusion reactions are a thing, and no one's surprised by it, so everyone's comfortable with it. It'll be the same thing, I think, with these bispecifics. Not exactly the same, but similar. So I think the hurdle to accessibility now is just community oncologists getting comfortable with them, and there's all kinds of different models to kind of facilitate that. One version is that maybe the academic doc treats the patient for the first few weeks until they get over that little hump of the risk, and then we send them back to their community oncologist. They don't have to drive back and forth so much. That's one model, and there are other models as well. In a couple of years, the community oncologist will be very comfortable with these, so it'll be less of an obstacle. One little reason I think that also the community oncologist a little bit uncomfortable with them is that we have for multiple myeloma, a different disease, but a distant cousin of lymphoma. We have bispecifics for those as well. And although I'm not an expert, the numbers are that those actually have a little bit more toxicity in terms of risk of infections. So the community oncologist knew about those first, and maybe they had a bad experience. Maybe a patient got an infection while getting treated for them. So when then they hear bispecific, they go, oh, well, that sounds a little concerning. These the numbers are extremely different. The amount of infections that patients get with these bispecifics is like less than twofold compared to the myeloma bispecific. So that's a little obstacle, I think, for community oncologists as well. They are a little bit concerned about it, but I think with comfort, then that will be less of an obstacle.
That's great color. Thank you, Dr. Brody. Dr. Bello, do you have anything to add there?
No, I agree. I think it's just a matter of comfort and then like all drugs, once they're out for a few years and people become more comfortable with them, they'll become more readily available at multiple locations.
Awesome. I'm going to circle back to that community and academic oncologist question at the end after we get done talking about a million novel treatments, right? And how complicated sequencing is. But now we jump to CAR T after you guys have talked some smack onto it, right? On its toxicity profile. Still obviously a major player, as you said, Dr. Bello. We just, Lysocell was just approved, or Lysocell, however you say it, Transcend. We also have Axicell, Tisacell, so 3 FDA-approved options, always tons in the pipeline, targeting anything you can find on an IHC, right? So can you kind of explain, we talk about what bispecifics are, what's the difference between them and CAR T, and the mechanism of action for CAR T? Dr. Bello?
Yeah, like Dr. Brody mentioned earlier, they're kind of similar. The mechanism of action is just kind of obtained differently. So for CAR Ts, much more complicated process, I would say, in that basically we have the patients come in, they donate blood, and the blood goes into a machine that filters out their lymphocytes, and gives them their whole blood back. So we're not taking all of their red cells. And then we take that bag of lymphocytes, and we send them to a facility that will engineer the cells, specifically the T cells is what we're looking for in that bag of lymphocytes, to recognize a marker on the lymphoma cells. In the 3 products that you just mentioned, the marker is an antigen called CD19, which is pretty much common in almost all B-cell lymphomas. But they also, in addition to the T cell being able to recognize that antigen, they also program the T cell to be turned on, because the T cells by nature are, when they're in your body and floating around, they're not just attacking your body randomly. They have to have a trigger to turn them on. So these are basically T cells that are engineered to recognize a certain antigen on the lymphoma cells, and they're activated already. So when that's ready, they ship them back. Usually takes a couple of weeks for them to do this. And then what we do is we have the patient come in, and we give the patient a small dose or moderate dose of chemotherapy over a couple of days to kind of suppress their immune system a little bit so the T cells will work a bit better. And then we give the patients their T cells through a transfusion, so through their vein, through a catheter. And when that happens, once they get into the body, they immediately start to attack the lymphoma. And a lot of times we hospitalize people for this portion of it, because now is when they're going to start to get the cytokine release syndrome, the high fevers, the drop in blood pressure, the fluid shifts, sometimes shortness of breath, um, and then the confusion, the neurologic toxicities, either something as simple as just lethargic, to as severe as can be basically comatose from it. So we monitor these people while they're in the hospital because there are tests we can do to follow these people to see if they're going to start heading that way, where they're going to start getting more severe of these cytokine release symptoms or neurologic symptoms. There's some blood tests we do to follow them. And we do have some medicines we can use to attenuate some of this if we start to see it happening. So the patients are in the hospital um, really anywhere from 7 days to 3 weeks during this. It just depends on how long this whole inflammatory process lasts in the body. The inflammatory process can start as soon as the cells are put in. So it can start within a few like an hour. It can start a couple days. So we don't let them go home, within 24, 48 hours just because they're doing well, because it can happen a few days later. Um, but then there's kind of a peak in the symptoms. And then you'll start to see the inflammation kind of starts to lessen, and the patients start to uh, get more back to, I guess, their baseline or their normal status. And then we eventually let them leave the hospital, and they're obviously their work is not done at that point, because usually when they leave the hospital, their blood counts will be kind of low, because even though it's an immune therapy and we think that, okay, it's just attacking the lymphoma cells, it does cause quite a bit of a drop in the white cells and the red cells and the platelets. So some of these patients are requiring some transfusion support during the first few weeks afterwards, and antibiotics, because we do see infections happen too with the low white cell count. Um, but that's kind of the whole process in a nutshell. And the weird thing with it that I always found weird with the CAR T therapy is that sometimes people get very sick for like a few days, and then like a light switch is turned off. It's like all of a sudden inflammation stops, and all of a sudden, like the next day, you go in the room and they're like, "Hey, how you doing?" And you're like, "Wow, okay." You should have seen yourself yesterday. But once that inflammation kind of lessens, the patients start to kind of get back to normal. So it's kind of like I always tell my patients, and pardon some of my language, I always tell them, you're going to have a week of hell, and then you're going to feel all right afterwards. So
I'm really glad you said that, because all the time you see like caregivers come in and they see these neurological symptoms, and seeing someone have like aphasia or tremors, and you like, I'm glad that we're reassuring most of the time it's transient. It's like terrifying for the patient. Like honestly, it's going to be a blur, right? But for the caregivers, it's like the most terrifying thing in the world. And I think like 15% of people with the newly approved lysocell had neurological events. I think lysocell, I'm not sure. I think it was the lowest in terms of that. So yeah. So I mean, like a decent chunk of people are going to have them. So it's like this scary thing, but it's transient the majority of the time. Okay, awesome.
and I think it's good to let them know, because I don't know, there's some kind of conception or misconception out there in the community that CAR T and immunotherapies are like benign. Like they come into the office and they're like, I don't want chemotherapy. I don't want that. I want CAR T. And you're like, are you crazy? No, we're not going to just skip straight to that. I'm like, this is a intense treatment. It's not something that's just, oh, it's going to be a walk in the park. So, and I think it's been, I don't know, there's a misconception out there that it's like, oh, it's not chemo, so it must be easy.
I bet it's because when it was first approved, right? It's like it's replacing transplant, and which is like a giant, right? And so people are like, well, it's better than that. So people are talking about less toxicity, and people translate that to, oh, they're gonna, it's nothing. Like it's no
Yeah.
big deal at all. Yeah, that's great. Thank you.
I love that the conversation is really about this expectation setting as best that you can. Of course, people have different expectations, but being able to, have the conversation lean in, let them know this might be something, this might not be, but so they're not, very unpleasantly surprised. So I really do appreciate that. Um, Dr. Brody, with so much development that is happening in the immunotherapy space, like CAR T, like bispecifics, you talked about top secret things earlier. I know doctors don't like the word cure, and oh no, the second hardest question so far in the discussion. But is there discussion about that? And if not cure, what's the consensus on the impact to longer periods of survival?
Yeah, that is the second tough. So far, there may be another tough one later. Let's see. Yeah, doctors, but especially academic doctors, are extremely diplomatic. It's actually kind of annoying how diplomatic we are as a group. We're not as bad as lawyers, but it's kind of like we say this to patients all the time, because you mentioned cure. So we say that follicular lymphoma is incurable. That is an idiotic thing to say. There's nothing that's incurable. We just have not found the cure yet. That's on us. It's not the disease's fault. It's us. There's nothing magical about the disease. We just have not been smart enough over the past 40 years, but we are getting close. And so let me comment that my hope or belief for the future. First of all, a lot of things were incurable. When my grandpa's sister, he gave me permission for this, had Hodgkin's lymphoma in 1949, it was 100% incurable. Now it is 85% curable. And that's not that long ago. So yeah, nothing's incurable. It's just we haven't found the cure yet. We refer to follicular lymphoma as incurable. That's still how we write it in all of the papers. First of all, that sounds scary. It's a terrible word. Then whenever I say that word, I have to say it's incurable, just like high blood pressure or diabetes. Just as Dr. Bello said, we do not have a cure for high blood pressure. We got pretty good pills that can keep your blood pressure good for the next 50 years. We just can't give you one pill to cure it. And so that's what we say for follicular lymphoma so far. But again, it is not incurable. It is just that we haven't found the cure yet. And quite honestly, I would not be surprised, this is an undiplomatic thing to say, that if we look back in 20 years from now, we will see patients who are getting and again, bispecifics have been the highest bang for the buck in follicular lymphoma in terms of bang for the buck, I mean efficacy for the toxicity, have been the highest bang for the buck medicine for follicular lymphoma ever invented. So by themselves, they have some limitations. They're good but not perfect. But in combinations with standard therapies like rituximab and lenalidomide, as were mentioned, the remission rates, the complete remission rates have been huge in just the first early studies. The big studies are getting done now. I would absolutely not be surprised if we look back in 20 years and say, well, the folks that got those bispecifics plus combination standard therapies never relapsed, and we watched them for 20 years. And it will not be for 100% of patients, but it'll be for some fraction of patients. I do not have a time machine. I don't know that will happen. I just absolutely would not be surprised, because so many people are getting such deep remissions. There's nothing magical about follicular lymphoma that it can't be cured. So we call it incurable today. Maybe it is, but it is possible. We are handing out curative therapies to people on those studies today. And if you ask me what's the likelihood, I don't know. Ask me again in 20 years. But it's a real likelihood.
So we've talked about the fun ones. Now we're going to go to the ones that are probably the most confusing for patients, which is all the inhibitors, the 300 million inhibitors, right? There's BCL2, BTK, SYK. There's so many, and some of these are FDA approved. So where do those fit into this new paradigm with CAR T and with bispecific antibodies? Dr. Bello, how do you use them in your practice?
Well, unfortunately, the data with these in follicular lymphoma has not been the greatest with the BTK inhibitors. So the BTK inhibitors, it stands for Bruton's tyrosine kinase inhibitor, and we use them a lot for other types of indolent lymphomas like small lymphocytic lymphoma, chronic lymphocytic leukemia, Waldenstrom's is a pretty nice success story with that. But with follicular, it hasn't really worked out well. There are some studies in development looking at it more so, combining some of the BTK inhibitors with maybe like a anti-CD20, but so far they haven't looked that great. The other one is the BCL2 inhibitor, venetoclax. That one is still a shocker to me. I'm still getting over that one because BCL2 is what's like mutated in like 99% of follicular lymphomas. And then this drug that blocks the BCL2 pathway doesn't work in follicular lymphoma. So it was like, oh crap, we still don't know what we're talking about. So I don't really see I don't really use them in follicular lymphoma. And then probably the one that really had the best results was pulled from the market was the PI3K inhibitors, and they got all kind of either voluntary or involuntarily removed. And but I think nowadays with thankfully we do have these other options that I really don't miss them too much, and so it's okay. But I don't really see them unless they get more fine tuned, or different, maybe different receptor affinity. I don't use them in follicular.
I actually am going to kind of flip this around. We had specific questions, but would love to ask you, when it comes to clinical trials, are there ones that are particularly exciting for you in the follicular lymphoma space? And keep it more open-ended.
First, I have to make a comment about clinical trials more broadly, which is clinical trials are not always great. Some of them are bad. Some of them are medicines that turn out not to be great. However, clinical trials are just a time machine into the future. Like I was saying before, we have been giving people some of these bispecifics, sometimes in combination, for about 4 years now, maybe 5 years, and some of them are just getting FDA approved now. And then some of these combination therapies are not FDA approved yet, but they will be FDA approved in the next 1 year, for in some cases, the next 5 years in other cases. So we have patients who got in 2019, 2026 therapy. What in 2026 will be agreed to be, this is the FDA approved therapy, but they got it 7 years earlier. So it is kind of a little bit of a mini tragedy that Americans don't get the access to these, and mostly just for lack of kind of awareness. These things are pretty accessible. They're available at, many dozens or sometimes hundreds of hospitals around America, but just they didn't think to ask, or maybe they asked and the person they asked wasn't aware of them. That's where things like the Patient Story, Lymphoma Research Foundation, LLS, can be super helpful in guiding patients toward this stuff. And there's no absolute commitment to go and be part of a trial, but just to hear about it, just to decide, why not get the information? For all big problems in our lives, we should get the information. If you got to get a mortgage, you're going to hear about a couple of options. You don't want to commit to this big thing until you at least have heard the options. So, we were talking about like frontline therapies for follicular lymphoma before, and then hinting at later lines. The NCCN guidelines are super clear. These are the National Oncologist Guidelines. They say, we recommend finding out about clinical trials. It's written right there on top because of what we said, that the old therapies are considered non-curative, and doesn't mean we can't get a curative therapy with some of these promising trials. So that is, the first thing that patients need in the beginning of their journey is the awareness that there may be some self-advocacy involved. Your doctor, your oncologist is your advocate, but still there may be some self-advocacy involved as well. Thank God with Google and the Patient Story and all of these other resources that people can advocate for themselves pretty easily now, but they do have to do it. The patient or the patient's spouse or kids or whatever should be doing a little searching around. And a couple of folks here mentioned second opinions and third opinions. No doctor in America should ever be annoyed if a patient goes and gets a second. And I am a doctor. My patients go get second and third opinions beyond me. I'm always like what they tell you. I'm always interested to hear because, as Dr. Bello was saying, there is no right and wrong answers for most of these situations. So why not get a couple of opinions? And if a patient comes to me from 4 hours away and we don't have any great trials for them, or we have a trial, but I don't think it's that great for them, we just send them right back home and say, well, here's some options, but I don't think you need to get it. And if we have a trial that is amazingly awesome for them, thank God that their daughter told them to come and do this appointment. So that was a long-winded saying of the importance of just being aware of trials. And also that people think of trials, oh, this is such a bad branding for trials. They think of it as a last-ditch effort. When everything has failed, oh, let me go look for trials. That trial would have worked real good for you if you weren't already in such a terrible place because you got 11 lines of chemotherapy and you're not super healthy now. So it was a shame that we thought of them as the last-ditch effort. It should not be. It should be a first-ditch effort, if that's a word. And we have trials for frontline therapy, second line therapy, plan A, plan B, and the trials we have for plan A, first line therapy, are things that we're super excited about. So, Steph, your question was, what are ones that we're excited about? And yeah, a couple of them. One example is getting these immunotherapies instead of chemotherapy. So we have trials of frontline therapy of bispecifics, for example, where half the patients get that and half the patients get the standard therapy. It could be chemo or other things. Also, patients have a concern that they're a guinea pig and they don't know what they're getting, or they're getting placebo. Yeah, there's no such thing as giving people just placebo. They may get standard plus a placebo on top of that. And in almost all of these trials, people are aware of what they're getting. There's no mystery. So some of the most exciting trials are the chance to skip chemo, to get just frontline bispecific antibodies. And some other exciting ones are combinations of the standard with or without the bispecific on top of it, because the bispecifics have been pretty gentle, mostly safe. We can pretty safely combine them with standard therapies. And some of the early versions of those trials, the early results, we presented some of them at ASCO and ASH this past year. The remission rates have been unparalleled. They've been awesome. So yeah, I think some of those frontline, even second line trials of similar combinations are, for me, some of the most exciting trials out there right now.
No, I agree. The same thing. I think the bispecifics or immunotherapy treatments moving the trials that are moving them up now in the second line and even front line to me are the ones that are the most interesting that are in development now. Because if you could get a non-chemotherapy approach, I think that would be great. Now, again, we always have to be careful because when we find out years later, oh, guess what? Um, this drug caused this this kind of malignancy or this kind of immunologic problem later on. Maybe we should have just stuck with the original original treatment that we had. But I think the immunotherapies are the wave of the future, and the sooner we can move them up, the better. And those are the trials that I'm really looking for the results in.
In many ways, it's just a rehashing of, 20 years ago, rituximab was approved as a monotherapy by itself. And now we say that rituximab is chocolate chips. Just add it on top of everything, put it on top of ice cream, yogurt, salad. Okay, I'm not sure about a salad, but there's not a single B cell lymphoma where you don't add rituximab on top of whatever the standard was before. And they are better. I mean, CHOP was the standard of care. No one talks about CHOP anymore. R-CHOP is the only thing now, except for some newer versions of R-CHOP as well. So I do think that will be the standard in 5 years from now. So, wait 5 years for the better stuff, or go quietly get access to it now.
I would like to actually, just because for the sake of time, expedite it a little bit. So just to wrap, I do want to plug the LLS, the Leukemia and Lymphoma Society has a clinical trial support center that is free one-on-one support where you can call them. We'll put the information right up here. You can call them, get connected to a clinical trial nurse, a nurse navigator. We work with them quite a bit. It's free, and they're able to talk about, how to find the right trial all the way through when you are on a trial, making sure that you have your questions answered so you stay on the trial. But to repeat back what both of you said, clinical trials is not a last resort, that people should understand that placebo is not what they think, right? It may be placebo on top of standard of care instead of standard of care or the experimental arm. And so the terminology itself, I just said experimental, clinical trials, all of those things I think can be quite daunting. So being able to understand a little bit more about what this actually is so that people can make the decision for themselves with their healthcare team, I think is amazing. One last thing about the Clinical Trial Support Center, these nurse navigators will help navigate, because we talk about clinicaltrials.gov, and I know they underwent like a makeover, but still not necessarily the easiest site to navigate. So it is great, clinicaltrials.gov, but also the Clinical Trial Support Center can help you navigate even a resource like that. So thank you both so much for that. I believe, Dylan, you have a question about the different sort of sequencing. Yeah.
You touched on a very important point when you were talking about second and third opinion. So all the time, especially online, a lot of people will come and be like, when is the right time to get my second opinion? We talked about a ton of therapies today, really complex sequencing patterns after you get past the first two. We didn't even talk about stuff like antibody drug conjugates that are in trial, even though there have been some failures, and these inhibitors, which are still in trial, some of them, even though there have been some failures. If your loved one or you has follicular lymphoma, when is the time where you're thinking, I'm going to go from a community oncologist and maybe get an opinion with someone whose whole job is being a lymphoma specialist and they focus on one type of cancer. And there's a little subsequent question, kind of just to clear the air on this. Can you explain the difference between a lymphoma specialist and a hematologist oncologist? Because a lot of people, the hematology is the assumption is they're lymphoma experts by default because they did that extra year, that fellowship.
So let me first say that community oncologist is a tough job. Most of these folks are taking care of lung cancer, breast cancer, kidney cancer, bladder cancer. It goes on literally all day. And I look at their job because I'm buddies with the dozens of them that work right around me. And I hear about what they did today. And oh my God, I didn't know that there was a new lung cancer. I didn't know there was a new breast cancer. And they have to try to stay on top of all this. It's a very tough job. And so, I think we have a pretty good way of working together. Hopefully, the academic oncologist and community oncologist, which hopefully means they have my cell phone, and for any little thing, they give me a buzz or give me a text, and it's pretty easy. And for most of those texts, the patient doesn't need to come see us. They just say, "Oh yeah, that's easy. Just go down one dose, and it'll probably be better tolerated," or whatever the simple question is. But compared to breast cancer, follicular lymphoma is a rare cancer. So your regular community oncologist knows about follicular lymphoma, has had a few patients with it, but every month they are seeing dozens and dozens of breast cancer and lung cancer, and probably zero follicular lymphoma, and they'll see a few per year. So it would be impossible for them to stay on top of every little bit of data update that, oh my goodness, the new bispecific data were unbelievable. There's no way they could do that for every single type of cancer. I mean, Dr. Bello and I can barely do it for all the types of lymphoma. So you can imagine that plus 1,000 other cancers, because the data is thankfully a lot and frequent, and the updates are significant. They're not just maybe as they were in the 80s, another rehashing of the same chemo with the same results. They're not that. We are getting new FDA approvals like almost every month, a few times a year for sure. So it's not possible for them to stay on top of all that. They have a lot to do. And so the answer for when to see a specialist is always, always. However, thank God, most patients do not need to keep seeing the specialist. They can kind of have a back and forth where we share the patients. I have to say the most common intervention I make where there's a difference between my opinion and the community oncologist, it is usually that they need less, with follicular lymphoma, that they need less therapy. It is frequently that they come in and say, my community oncologist said I need R-CHOP, and I say, you don't. You do not. In fact, you definitely do not. And I don't fault them for saying that because, as Dr. Bello is saying, there's not always a wrong or right answer here. But all we see is lymphoma. That's the difference between a lymphoma specialist and even a hematology focused oncologist, where they're seeing AML, MDS, myelofibrosis, myeloma most of the day, and then a little bit of follicular lymphoma. All we see is lymphoma. It's all I've seen for, I don't know, the last 20 years or something. I know I look very young, but just cucumbers and yogurt and stuff. But it's been a long time, and that's all I do. So yeah, we have to have sometimes just a little more experience in these not that common diseases. And the most common interaction I have is that we downgrade the need. They don't need that aggressive chemo. They can get either nothing, active surveillance, or something gentle is the most common thing. And also we make them aware of cool trials where they may get secret access to a thing that won't be available for sometimes years. So when do they need to see a lymphoma specialist? Always, but they don't have to continue seeing them. If it's a 4-hour drive, they'll just see us once a year maybe and see their community oncologist every 3 months for check-ins. And maybe they got another PET scan and now the community oncologist is not sure, so then they come back and see us again. So the answer is always.
Thank you. Then we're wrapping this with the last takeaway. Really, we've had an incredible discussion. Thank you all so much for being part of this discussion. What is the final, if someone's been listening, hopefully many things have resonated, but if there's one thing that you hope people are walking away from this discussion with, what would you like that to be? It could be something we covered, it could be something completely different, but just in the follicular lymphoma space. Dr. Bello, we'll start with you.
I think one of the most important things, kind of what we touched on in the very beginning, is that it's okay to not get treatment with this. There are a lot of times where people don't need to have their lymphoma treated. So if that is the recommendation your doctor is telling you, they are probably not insane, maybe a little, but they, but it's correct. A lot of low-grade follicular lymphomas can just be observed, and coming to terms with that and knowing that you're being monitored, and that if something does change or something happens, we have options for you. We have great options. I think is really the take home, is that we don't all need to be treated. Lymphomas are very different than what we call solid cancers, like breast cancer, lung cancer, where all of those need to be treated. And usually the sooner the better. This is like you have to kind of change your whole mindset with these kinds of conditions.
Thank you, Dr. Bello.
Yeah, Dr. Bello said it beautifully. I agree with just how she said it. I guess I would add that if you get diagnosed with follicular lymphoma, number one, thank God you got follicular lymphoma and not some bad, horrible lymphoma, because it could have been something else. Number two, thank God you got lymphoma in 2020s and not in the 1990s, because the advances have been unparalleled. There's no cancer where the advances have been as incredible as in lymphomas and B-cell lymphomas, like follicular lymphoma especially. And yet also I would say I guarantee that the 2030s medicines will be better than the 2020s medicines. So some patients will be savvy enough to get access to those even now.
Clinical trials plug. All right. Thank you, Dr. Brody. Thank you, Dr. Bello, and to Dylan too for helping to lead this discussion. Really appreciate your time. All right, and we'll also be sending links to the LLS's Information Resource Center, the Clinical Trial Support Center, these incredible resources that are for free and cover such a range of issues in cancer care provided by the LLS. We'll also be sending links for social support, including a follicular lymphoma Facebook group led by our friend Nikki, a follicular lymphoma patient advocate, and a place where you can find some community as well. So we'll drop the links here as well as in our follow-up email, so be on the lookout for that. One more time, I want to say thank you to GenMab, our sponsor for this program. Again, the support allows us to do more of these programs and keep them free for our audience. And again, I mentioned this survey before, so important for us to hear from you. So please take a few minutes to fill that out so we can hear exactly how you think and feel about the content that we're putting out there. So I hope that you enjoyed the discussion that happened today, and we hope to see you at a future program as well. For now, I am Stephanie Trong with The Patient Story. Take good care.